Hello, good afternoon. Welcome everyone to Department of Medicine Grand Rounds today. It is a real pleasure for me to introduce today Dr. Saad Mussarat, one of our outstanding faculty member here at Eastern Virginia Medical School in the Department of Medicine. He is an assistant professor. He serves as Associate Program Director of Internal Medicine Residency Program, and also he's Director of Medical Grand Rounds, Department of Medicine Grand Rounds, a role for which we are very thankful. And we have seen, how Grand Round series goes. So thanks to Dr. Mussarat for that. He's deeply committed to medical education and plays a central role in teaching, curriculum development, and mentoring residents and medical students. He received his medical degree from King Edward Medical University and completed his internal medicine residency right here at Eastern Virginia Medical School, and then joined us as faculty about 4 years ago. 4.5 years ago, something like that. Yes. He is a highly respected clinician and an educator. He has authored peer-reviewed publications, has presented his work at national and regional meetings on a broad range of clinical topics. He is board certified in internal medicine and is an active member of American College of Physicians, Society of Hospital Medicine, and the Alliance for Academic Internal Medicine. Beyond his clinical and educational roles, Dr. Mussarat brings a forward-looking perspective to medicine through his strong interest in the intersection of technology and healthcare. He recently completed a certificate in artificial intelligence in healthcare from the MIT Sloan School of Management, reflecting his commitment to understanding how emerging technologies can meaningfully improve patient care and medical education. His current interests include application of AI in clinical decision support and workflow optimization, with a focus on enhancing both efficiency and quality in healthcare delivery. We are very fortunate to have Dr. Mussarat as a colleague, an educator, and a leader in our department. And I know today's talk will be both timely and highly relevant to all of us. Please join me in giving a warm welcome to Dr. Mussarat.
Thank you, Dr. Qayyum. All right, thank you everyone for joining today. I do not have any actual or potential conflicts of interest in relation to this presentation. Going over the learning objectives, we will define and differentiate some key concepts in artificial intelligence. We'll review history of artificial intelligence. We'll discuss some emerging uses, limitations, and ethical considerations for the trustworthy implementation of artificial intelligence. Let's go back a few hundred years ago. In 1712, Thomas Newcomen built the first practical steam engine. It was just a simple machine to get water out of the coal mines. It was a clunky machine, did not work as it was supposed to, but in 1782, James Watt refined it, and suddenly this machine could power mills, locomotives, and became the cornerstone for the Industrial Revolution. I asked one of the LLMs to create a video demonstrating working of the steam engine, and this is what I got. I asked another LLM to create a similar video, and this is what I got. So there are two analogies I want you all to think about. One, we have this world of artificial intelligence that could be compared similar to what Thomas Newcomen built in 1712. Second, going forward into the talk, we'll talk more about it. But I want you all to remember how these two videos look different from each other, how the two Thomas Newcomen look different in each video, and how the background was different, and how these videos, we think are very close to the original model, because that would be the basis of a talk going forward. Every technology cycle, this was proposed by Jeffrey Moore from Stanford, goes through some phases. There's a first phase where we have technology enthusiasts, where venture capitalists, innovators want to invent things that would change the status quo. Then we have the mainstream market, where we have pragmatists and conservatives who would adapt this technology and use it to improve their life. Then on the extreme, we have some skeptics who would not believe in the technology no matter what. If you were a skeptic, I hope you're not in the room. So I think I have a very good audience today. Let's take an example of EVs. A few years ago, we thought about EVs as something that has range anxiety, may not work out that well. But today, fast forward, the range anxiety is gone. They're considered as a decent alternative to gasoline cars. So this is, another example of a technology that went through this technology adaptation cycle. Gartner is one of the leading advisory research firms. They create this hype cycle each year for artificial intelligence, and this is from 2025. I'll walk you through some of the important milestones of artificial intelligence. So one of them we see is generative AI, or large language models. We see it has a blue mark, that is, it will reach a plateau in 2 to 5 years. We have AI agents, that is, they expect this will reach a plateau in 2 to 5 years. We have artificial general intelligence, which we will talk a little bit more in the later part of our talk today, is expected, to be reaching a plateau in more than 10 years. And then we have this quantum AI, which we think will reach a plateau in more than 10 years. 4 big revolutions we have encountered so far. The first one was where we had the steam engine. Second, when the electricity was produced. The third one, where we had electronics and computers come in. And everybody believes that we are in the midst of a 4th industrial revolution, which will be based on artificial intelligence, big data, and robotics. Keeping this background in mind, let's move on to define artificial intelligence. So, AI refers to machines or softwares displaying human-like intelligence, performing tasks that typically require human cognition. It could be as simple as responding to a text-based query, creating an image, creating a video. An example would be if you came from home, you came to work and used maps, that is an example. If you're using voice assistant at home, that is also an example. So this all falls under the umbrella of artificial intelligence. We'll go over a brief history of artificial intelligence. In 1950, Alan Turing proposed his Turing test. This was essentially a simple test. If a machine can trick humans into thinking it is human, it has intelligence. So you have 2 responses, one from a human, one from a machine. But if the judge cannot reliably differentiate between the 2, it was said to have passed the Turing test, and that is, it has intelligence. In 1955 at Dartmouth, we had this a conference where John McCarthy coined the term artificial intelligence. Pretty much from 1955 to 1997, we do not have much development happening in the world of artificial intelligence. We do have the concept of machine learning at this stage. However, the 2 ingredients that are missing are, 1, we do not have access to data. And second, the computing power we have today was not present at that time. So there is almost a period where the technology is there, but we are not able to capitalize on that. In 1997, we had this big moment where Deep Blue, a chess-playing computer from IBM, defeats world chess champion Garry Kasparov. And then small development happened, like we have robots coming in, voice assistants like Siri, Alexa come in, ImageNet is there. The big development where our fundamental growth happened was in 2017. And that was this paper from Google, which was Attention is All You Need, which formed the basis for transformer architecture. And that led to the development of all these LLMs that we are familiar with today. Let's talk briefly about the types of artificial intelligence. We have 3 major types of artificial intelligence. One is narrow artificial intelligence, which is specialized at specific tasks. For example, pattern recognition, text-based query, video generation. This would all fall in the narrow artificial intelligence umbrella. Then we have artificial general intelligence, where we have AI with human level general intellect. That is a hypothetical concept at this point. Then we have artificial superintelligence, which is AI beyond human intelligence. And to explain that, I asked AI to create an image that will help you guys understand what are the three kinds of artificial intelligence. So let's look at the first one, which is narrow AI, where we have a robot arm playing chess. AGI, where we have a robot physician interacting with human physicians, and that is not present today. And then we have this ASI, which is hypothetical sci-fi creature in the sky and humans on the ground looking at that creature. From now on, what I will be talking about in the lecture would be the narrow artificial intelligence. In the artificial intelligence umbrella, we have machine learning. Machine learning is a set of techniques within AI where we are focused on learning from examples or patterns. Deep learning is further specialization within the machine learning where we are using deep neural networks similar to your connections in the brain. And then generative AI is an example of machine learning. Now we reach generative AI, and then the next pertinent thing we need to talk about is what is a GPT? GPT simply stands for G for generative. It generates text. P for pre-trained. It is trained on large amounts of data. And T for transformer, where it is processing all the data to come up with outcomes. Now, this might sound complex, but the key takeaway from all this would be that this is, one, a predictive model. And simply what it is trying to do is to tell us the most probable word that will follow this input. This is the paper from 2017, which we just mentioned, came from Google. Attention is all you need. How is it so relevant? Before transformer architecture, we had one, recurrent neural networks. In the recurrent neural networks, you would move from point A to point B to C to D. An example would be text messages. You are typing a text, and based on the last word, it can predict the next word, but it cannot look at the sentence as a whole and keep the context in mind and give you the prediction. This is a recurrent neural network. We have convolutional neural networks, which can process the data in chunks. They can look at different differences in images. They can recognize patterns and are used in diagnostic imaging. Then we have this transformer architecture, where you can write lengthy inputs. The computer can understand your input, have the capability to keep the relevance, and then come up with more appropriate outputs. A clinical example would be a student presenting a patient to the attending, and the attending can listen to HPI, vitals, labs, exam, and then come up with a differential diagnosis. Similarly, when you have the transformer architecture, all those things can be looked at one point, and you can get some output which is more relevant. The transformer architecture has three basic components. One is embeddings, the second is the transformer blocks, and the third is the probabilities. Embeddings are a way for a computer to understand your text, word, images into numbers that capture meaning. For example, if you write any command, it will be broken down into numbers, and similar numbers would be placed close to each other. For example, fever would be close to inflammation, infection, lactic acid is shock, hypertension. Transformer is where the computer decides how much to pay attention to all these variables. And then simply it is going to give you some probabilities, and the one with the highest probability would be your output. Let's see this example. This is from GitHub. So I wrote this sentence, how much is $1, and left it blank there. It went through embeddings. It was broken down into tokens. Then we had the encoding. Next thing that happened was, not to go into a lot of details, but The transformer architecture looked at it in different ways. And then we got this probabilities. So how much is $1? We could get the output worth. We could get the output per more spent, good, invested. But the highest probability was worth, so I got the output worth. Another example, the color of sky is, you would have embeddings, transformer block, probabilities, and the output would come as blue, 91%. Now, this is a predictive model. It is utilizing the data that is already present. And whenever there's data that's being utilized, the quality of output would depend on the data that is already present. So if there is some bias present in the data, that is going to be reflected in your output too. For example, Jane worked as you can see for Jane, the likelihood is journalist, teacher, reporter, lawyer. Jim worked as for Jim, the likelihoods are fisherman, policeman, salesman, mechanic. So if there is some bias present in the data, that is going to be reflected in your outputs. Let's take another example. Why does not he ask me out, want a relationship? Why does not she call, want me, love me? So there is some differences based on the gender in the outputs you're receiving. And that is because the data that is being trained on has some bias already present. To conclude the first part of our talk, which is what is artificial intelligence, or the types of artificial intelligence, the key takeaway messages are, one, it is a predictive model. Second, data is the key. Quality data means better results. Third, it cannot generate anything new at this point. We understand that it can just process the data. And lastly, because it is a predictive model, it will always have potential for hallucination. Now we'll take a pause here and we'll look at this painting together for 5 seconds. So this is one of the famous paintings by Sir Luke Floyds. He was an artist in Britain. His inspiration was his own son who died from typhoid fever. It is also referred to as the doctor. In this painting, we have a physician who is sitting at the edge of a makeshift bed. He has empathy, attention towards his patient. There's a child who is laying there with 2 chairs being used as a makeshift bed. The physician has already probably given medicine. We don't see much in his hands, no tools. There is this mom who is distraught, her head buried, and the father who is worried yet composed and trying to console the wife. He wanted to put the image of a physician in society's view. Let's compare it with today. We have better technology, we have better facilities, better medicines, but probably what we don't have is time at bedside. Can artificial intelligence revive our patient-physician relationship going forward? This is something we will talk about in the next part of our talk. This is from Dr. Linda Shin. She is a board-certified dermatologist from MD Anderson. She quotes, imagine if a doctor can get all the information she needs about a patient in 2 minutes, and then spend the next 13 minutes of a 15-minute office visit talking with the patient, instead of spending 13 minutes looking for the information and 2 minutes talking with the patient. And I think what Dr. Shin described is close to reality for most of the physicians. This was recently published in JAMA. And that was just the state of affairs for the artificial intelligence. At this point, we have 1,200 plus FDA cleared tools and 350,000 plus consumer apps that have generated a $70 billion market. We have 691 FDA cleared artificial intelligence or machine learning medical devices that have been approved from 1995 to 2023. So having said that, it already means that AI is well established in the field of medicine, but it has the prospects and the ability to have a much more meaningful, to have the potential for a much more meaningful change going forward. How can AI help us? It can essentially do three things for us. One, it can automate the workflow. For example, it can make patient appointments, send them reminders, notify physicians about critical labs and things like that, look into drug interactions with rule-based AI. It can augment the workflows. We can think about ambient AI. We can think about clinical decision support. The amount of X-rays a radiologist would read in 4 hours, it takes 1.5 minutes for an AI model to read them. So it can augment the workflows. Another example would be Viz AI, which is used at our facility too, where it can detect the large vessel occlusion in the stroke management patients and send a notification right away to the neuroradiologist or the surgeon. Again, augmenting the workflow. Is it autonomous at this point? Probably not yet. But when all these things happen, what it impacts? It improves the efficiency, it increases the productivity, and it leads to overall effectiveness in medicine. Now, we have to understand how generative AI and medicine became so relevant to each other. And this goes back to the HITECH Act that was approved in 2009. For those of you who are not familiar, there was significant federal funding for the adoption of EHR. We look at 2008 and 2009, we had 17 to 22% of the hospitals using EHR. Fast forward to 2013 and 14, we had almost 97% of the hospitals using electronic health records. So a lot of development that's going to happen in the world of artificial intelligence, especially generative AI, would be because of this vast data that is going to be present in our electronic health records. Let's go over an example. This is from Epic. They're building a predictive model that's called Epic Curiosity. And it is trained on Epic Cosmos. Cosmos is a large database that has de-identified patient records from 310 healthcare systems. It has almost more than 300 million patient records and 16.3 billion patient encounters. It is essentially a trajectory simulator, and it can do two things. From a clinical standpoint, they had 78 parameters in total, but some of the examples would be, from a clinical standpoint, it can tell you the risk of disease progression. It can give an idea about treatment outcomes. From an operational standpoint, it can predict the length of stay, discharge needs, and the bed flow in the hospitals. It will be available to the participating organization starting next month. Now, moving on, we have these large language models, and we had this whole hype, how they were good in medical question and answer sessions. This was a recent publication, and in this we can see that these large language models are even surpassing the human experts on USMLE style questions. The human expert is thought to have 87% accuracy, while we can see here Gemini, which is from Google, is surpassing that, and ChatGPT-4 MedPrompt is surpassing that. And GPT-4, which was the base model, was almost close to 85%. So now, when we have these large language models who are better than human experts, not just physicians who are ordinary physicians, but the best physicians in medical knowledge, does this translate well into the clinical world? This is something that researchers have been trying to look at. And it is thought that answering questions on USMLE exams does not translate very well into the clinical world outcomes. This is from Dr. Rodman and his team, and it was published in NEJM. And they used another method for the LLM testing. They use what's called the script concordance testing. And those who are involved in medical education would be familiar with it. Essentially, you get a scenario, and then you add a new piece of information. And then on a scale, you have to choose whether the diagnosis remains more likely, less likely, neither likely nor unlikely. So it's a 5-point scale. Now, these LLM performances were compared against large human cohorts involving 1,070 medical students, 193 residents, and 300 attendings across datasets. The conclusion they reached was they matched or exceeded student performance, but did not reach senior residents or attendings level on the SETs. And we can see from this graph here that the senior resident and staff were surpassing the performance on most of these SETs. As an example, we had GPT-4 reaching 85% on the USMLE-based questions. Here, GPT-4 was 63.6%, Claude was 58.8%, and Gemini was 54.4%. So where they were surpassing the human experts, it came down incredibly as soon as there was a little bit more uncertainty involved. This is from Stanford. Dr. Nigam Shah and his team looked at some of the ways how we can evaluate that these large language models, the potential they have is a reality. And they wanted to see how they can be helpful in a day-to-day operation life for a physician. So they had 5 categories in which they wanted to test LLMs. One of them was clinical decision support. Second was clinical note generation, patient communication and education, medical research assistance, administration and workflow. Then they have subcategories, which I'm not going to go into in detail, but 22 subcategories. The essential question was, these were deemed by a group of physicians the important categories that are helping us in our day-to-day activities as a physician. And the conclusions they reached were, it was best in clinical note generation, reaching from 0.74 to 0.85. It was good in patient communication and education, reaching from 0.76 to 0.89. It was moderate in medical research assistance, 0.65 to 0.75, and clinical decision support from 0.63 to 0.77. It was not that great in administration and workflow, but it also could be that some of the tasks they were being asked may not be that relevant for a large language model to achieve. So in a nutshell, where do we think the scope of LLMs is as of today? We think they're good for clinical decision support. They're getting better at clinical report generation. For example, discharge summaries, radiology reports. They are helpful in clinical research. Agentic AI is something that's being explored. They are good at medical question/answer based format, but they're not good at non-Q&A based format and clinical decision making where uncertainty is involved. So this was about generative AI. And now I will discuss some more uses of artificial intelligence in the world of medicine, which are not just limited to generative AI. This is a study in which they trained a large language model to classify primary bone tumors based on radiographs. They had 1,356 patients with histologically confirmed bone tumors, and their pre-op radiographs were identified from 5 institutions. And those radiographs were read by 5 radiologists. 2 of them were staff radiologists, and 3 of them junior radiologists. And they were compared with the large, the model that was trained with machine learning. And it was found that the model achieved similar accuracy to rate of 1 and 2 who were subspecialists and better than rated 3 to 5 who were junior radiologists. This is from MIT. Dr. Barsley and her team developed this model, which is called Sybil. It is a deep learning model to predict future lung cancer risk from a single low-dose CT scan. It was trained from the National Lung Screening Trial data, and it requires only one low-dose CT scan, and it can be run locally on your computers, and there's no communication that needs to be happen that would interfere with the risk of patient privacy. This is an example of a patient where they used Sybil. So there was a 69-year-old man with a 99 pack year smoking history and low-dose CT scan without visible nodules in the right upper lobe. The lung RATS classification gave a score of 2, which is consistent with benign and low risk, and Sybil risk was 75th percentile. 2 years later, after unchanged interval scan at 1 year, a new speculated nodule was appeared, and that's shown with an arrow. And resection confirmed a 2.2 centimeter poorly differentiated squamous cancer. So we had low risk on the lung RAD score, but 75th percentile on the Sybil risk. The idea is with machine learning, there could be subtle changes that be missed by a human eye, can be picked up by the model, and it can be used to predict the risk in the future. Utilizing AI, Christ Hospital went back into their patient records, identified the patients who had lung nodules, and followed up with those patients. They followed up on 5,000 lung nodules, and it led up to diagnosis of 116 additional cancers. And 64 of them started the treatment. So the idea is we had a model in which we could get the risk assessment, and then we had the use of AI where they reached out to the patients who had nodules present to follow them up and treat them early to increase the chances of good treatment outcomes. Dr. Langlotz is at Stanford, and he is also the director of their Center for Artificial Intelligence in Medicine and Imaging. And he quotes, "Artificial intelligence will not replace radiologists, but radiologists who use AI will replace radiologists who do not." I think personally going forward, this word radiologist could be replaced with physicians, and it would still hold true. Let's talk about this study that was published in 2018, actually. And that was from Dr. Michael Abramov, who is at University of Iowa. And his team looked at autonomous AI-based diagnostic system for the detection of diabetic retinopathy in primary care offices. The idea was in the patients who do not have access to ophthalmologists, whether due to limited resources, whether they are living in rural areas, to make it easier for them to be able to get this diabetic retinopathy screening done. And their model achieved a sensitivity of 87% and a specificity of 90%. And this was approved by FDA later on. They did a follow-up study that was published in 2024. And this was essentially looking at that this was a randomized trial. So they had patients between the age of 8 to 21 with type 1 and type 2 diabetes. The patients were randomized to one group was given a referral to an ophthalmologist. The other group got their screening done in the offices. And the study outcome was diabetic eye exam completion rate was higher, 100% in the intervention group where they were doing screening with AI versus control group, 22%, where they were sent to an eye care provider. To highlight it, this goes to show the potential of AI in primary care, in providing access to patients in a timely manner. This is something that would, probably interest more the geriatrics department, if there are any in the room. This is from Dr. Dina Kitabi and her team, where they developed an MRL device. And the device works in a way that you have, like a Wi-Fi router. It is going to detect the low power radio frequency signals from the room. And with machine learning, it creates a digital picture of the room. So with this creation of digital picture, it can infer people's movements, their sleep patterns, their sleep stages. It can analyze the gait and predict fall risk. The good thing about this device is it is doing this with the use of a camera where privacy concerns arise. Now, let's talk a little bit about ambient AI. I'm sure most of the physicians here in the room would have used ambient AI at some point now. And this is one of the studies, and multiple studies have been published after this. John Muir Health and University of Pittsburgh were some of the early adopters of AI charting with ambient technology. John Muir found out the clinicians who used it, they were able to save 34 minutes per day on notes. And University of Pittsburgh, they came up with this conclusion that it reduced the pajama time by nearly 2 hours each day. For the students who don't know what is pajama time, it is the time that you spend after you're done with patient care, finishing your notes. So if you had ambient AI where there is something in the room that's helping you with your notes and is able to facilitate that note portion of your encounter, then you are able to reduce your pajama time by nearly 2 hours. Because a lot of primary care physicians, if they have a busy practice, would spend an hour, maybe more than that, to finish their notes from that day after 5 p.m. Now, some of you might have seen this painting before, but this is from JAMA that was published in 2012. And this is the recollection of a 7-year-old girl who went to see a pediatrician in Providence, Rhode Island. She was accompanied by her mom and sister. In this painting, we can see there is a physician who is writing notes, typing stuff on the computer. The patient seems very happy. The older sister is playing with an infant, seems happy, and the mom is busy with some stuff. Now, this was just a highlight of the era in which High-Tech Act was forcing hospitals to adapt EHR. So this was considered to be one of the drawbacks of EHR adaptation. That is, the physicians lost the connection with the patients, and we had a physician with back towards the patient, completing their notes, trying to worry about that portion, while also trying to juggle with other patient care responsibilities. Going forward, hopefully, with ambient AI, we can have better eye connection with the patients. We can talk to our patients more, and a lot of the administrative stuff and cognitive load can go down. Briefly, we will discuss a little bit about artificial intelligence and medical education. So with the AI getting more hype after 2020, there has been a rapid acceleration in the number of publications. This is just a graph that shows how quickly we have seen go from almost nothing to more than 100 publications in 2022. Most of these publications have happened in the world of radiology and surgery, primarily because there's also a lot of simulation involved where AI is good at. Some of the uses we think that AI have in medical education could be a creation of knowledge-based assessments, simulated patients, creating chatbots, explaining difficult concepts, and providing feedback. For some of the educators who are in the room, we are all familiar with Bloom 2 sigma problem. So this concept was introduced by Benjamin Bloom from Chicago in 1984, where he observed that the students who received one-on-one tutoring performed on average 2 standard deviations better than the students who were taught in conventional classroom settings. So the idea behind some of these LLMs is they have something called the tutor mode now, where hopefully, it could be a personal teacher for you, where you could go back, understand some of the difficult concepts, and this Bloom 2 sigma theory could work out there. The next thing, prompt engineering. I'm going to talk briefly about prompt engineering because a lot of this is not relevant now. The reason I say that is a lot of these new models are becoming more smarter. They are better, and there is an underlying chain of a command where they are already doing this prompt engineering for you. Previously, most of you would have heard when you want to give a command to LLM, give a detailed command, role play, and things like that. But this is getting a little bit less important now. Some of the basic things still hold true when you are ever using an LLM. Think of it as the next best person who you could consult related to that field. Give the context definitely to get better outcomes. You can use the web search feature on as it decreases hallucinations because it would go in real time and look at the web and then come back with an answer. And it can also cite you the sources from where it got the answer. There is, in most of these LLMs, a feature called deep thinking, where you can do an extensive research on a topic. And then, most importantly, for the medicine, consider using LLMs with explainability, interpretability. That is, they can tell us how they reached this answer rather than black box models where you do not know what happens between input, then you have this black box and you get the output. But in these LLMs where there is explainability, such as open evidence, you can have references for the answers that the LLM is giving you. We'll talk about some of the ethical considerations and challenges of AI. AI systems, we briefly touched in the beginning too, can inadvertently learn biases present in the training data, and it can lead to unequal performances across patient groups. This was in Washington Post, where a medical algorithm favored white patients over sicker black patients. And this is, overcorrection, where Gemini got it wrong when they initially launched their model. This is what we were briefly talking about, transparency of black box issues. In the transparency of black box issue, you have deep learning models that are complex. Clinicians would not know why an AI made a certain prediction. And now the open evidence and similars, in what happens is, for example, here, you would ask how to treat pulmonary embolism. You would get a response, but the good thing is you would also get references which you can check in real time. So my suggestion would be, especially for patient-related matters, try to use an LLM that has explainability and interpretability. LLMs we discussed in detail are predictive models. Simply, if you could take away one message, that would be it is a fancy version of autocomplete. If we forgot those things, embeddings, transformer, outputs, all of that, it's just, remember, it's a predictive model, and it is just trying to tell us what will be the next best answer. When it is trying to tell us the next best answer, we will always have potential for hallucination. So hallucinations, while they have improved, they still remain a worry. And this is an example which I did yesterday. So you can go to one of these LLMs, it's ChatGPT here, but you can go to others too. If you use the previous model, which was 4.0, I asked, is 3821 a prime number? Let's check if it is a prime number. And I get the answer, no, this is not a prime number. And then it explains it to me with confidence and tells me it's a composite number, but it's actually a prime number. And the explanation is also wrong. And then I went to ChatGPT 5.2 and I asked the same question. Is 3821 a prime number? Yes, 3821 is a prime number. And then, it gives the explanation. So basically, if it's divided by 1 and the number by its own, it's a prime number. But the problem is, when it is wrong, it does not hint you at all. It is wrong. It is very confident in whatever the answer you're getting. So the SCTs, even we talked in the earlier portion of the lecture, one of the other problems was it was very confident. It would go from extremes, very likely to very unlikely, but would not try to stay in the middle, which is that it would not be so sure about the correct answer. And that is where, a human in the loop has to be there in the world of medicine. It can also pick up some spurious correlations. This is, an example of Anne Hathaway effect. So Anne Hathaway, whenever she would make an appearance for any, movie, awards, anything like that, Berkshire Hathaway stock would go up or down. And some of the algorithms, because of the last name, they were confusing the Berkshire Hathaway stock with Anne Hathaway, and the news would make that change happen. So it can pick up these spurious correlations too. One of the important things in medicine is privacy, HIPAA. Whenever you're typing something in the patient information, in the LLM, it becomes part of the training data. So you have to be very careful with putting in your own personal information too in these LLMs. If you sign up for Notebook LM, which is your own personal LLM from Google, it does give you this warning. Bear in mind that it's best to avoid submitting information you would not feel comfortable sharing. In the world of medicine, it's important to protect patients' privacy. So there would need to be safeguards, and we will need to be careful with which LLM we're using and how we're using the patient information. This is an example from 2024. We had an article that was published, and the article actually started like this. Certainly, here is a possible introduction for your topic. So somebody just produced this in a large language model, submitted it to a journal, and somehow the reviewers did not catch it, and it got published. The article was later redacted, but this is a great example how much AI we will be seeing going forward in the future. Now, in the world of research, you worry about plagiarism. This is in the beginning where we had ChatGPT 3.5, and this was an application that would detect if it was AI generated or not. And you can see how much we can see here AI generation. Now, when it went to ChatGPT 4, we went on the other spectrum, very unlikely AI generated. So do we think everybody became more honest? Or do we think these LLMs became smarter? The LLMs probably became smarter. And second, these detectors, they're not getting that much money to do research and catch up with the development that's happening in the world of artificial intelligence. So this is something that would be an ethical dilemma going forward, and we'll have to be very careful with how we manage this. So this is another example, real life example. we had these letter of recommendations. Somebody wanted to generate a letter, which is fine. But then the person who was named Andres suddenly became Anthony. And then someone who wrote a letter, it says, please do not hesitate to contact me at email/phone number if further information is needed. So it would be difficult for someone who is reading this letter to interpret what is true, what is not true. If you use it, please proofread it. With this, I will summarize my talk. I think we all can agree that artificial intelligence is the fourth industrial revolution and probably one of the most important ones. Today's AI is not perfect. It's jagged, good at certain things, bad at certain things, but it's a work in progress and will lead to meaningful changes in the future. When you use an LLM, think of it as an next best human, somebody who you can use for exploring different ideas, brainstorming, and other things. AI has enormous potential to improve healthcare and medical education. Implementation of responsible AI is more important than AI alone. Education and adaptation are crucial for the future. And my big takeaway is AI plus human is greater than human alone or AI alone. With this, I would quickly share with you an update on behalf of the department that will be launching our inaugural group for the AI in Medicine Interest Group. This is an effort that is supported by a PEG grant through the Office of Faculty Affairs and Professional Development, and Dr. Lieb is leading this effort. And our first meeting would be on January 29th from 5:30 p.m. to 6:30 p.m. So please, spread it with your colleagues and do attend us in person if you can. And with this, I'll wrap up. Thank you so much, everyone.
Questions for Dr. Mussarat? While everyone else is trying to check what questions to ask, let me ask my question. So when do you think AI will replace physicians? Would that be after my retirement or before that?
So that's a very good question. I think there is this fear that we all have that AI can replace us. But so far, from what we talked about, it does not seem like AI has the capabilities to replace us. It is good in certain things. It is more so like a tool we would have in the back of our pockets, I think, like a stethoscope, or ultrasound, that will improve us rather than replacing us. I think medical knowledge aspect we discussed is one. Clinical knowledge, we saw how it goes down with uncertainty involved. And also, when we are working in real life, there are subtle things that you can see examining a patient, subtle changes that make you make certain big decisions. So AI right now is quite jagged. It's good at some fronts, but not great at any of them. So I do not personally think it is going to happen before your retirement. Maybe when I'm about to retire, maybe. Hopefully not.
I thought you were older than me. Other questions, Salvatore, please.
Yeah, thank you. Great presentation. I have a question. So while signing in, I saw that today we had a probably larger than usual attendance of M1 and M2 students in the room, which is great. And so recently I read a paper in Nature. They were discussing when would be appropriate to start using generative AI or AI in general for education purposes, especially as a way to spark curiosity and really think about out of the box as a person, as an individual. And one of the concern was that if you start too early with using AI, that curiosity, that really ability to think out of the box, outside of the box, and have your own ideas might be affected. And so since we have a lot of students here, I think AI is very helpful, like you mentioned, for education purposes, to learn, to use it as a one-on-one teacher, instructor. But how can they make sure that they're still developing their own intelligence and curiosity, and develop their own ideas that can separate them from each other, instead of avoiding them to be very similar among all the students? For us, we trained where I trained in Italy. We didn't even have internet at my university at the time in college. So very different environment. So thank you.
So great question. We can look at it in different ways. If you look at the computers, if you look at textbooks, there were skeptics at that time too, that we are going to make it easier for students to understand things. We're going to provide, some of the resources that we should not be providing at this stage. In the world of aeronautics, the pilots, when they fly airplanes, that's mostly, autopilot. What they do is they do turn that autopilot off and want to see how they manage without any added technology that is available to them. So I think one of the things that we as educators will need to figure out is, how do we keep that instinct, the human instinct, where we trust our gut, in medicine? They say, if your gut says somebody is sick, you have to think a little bit more about it, because your gut is a very expensive gut that you developed over the course of time with knowledge, with hard work. And it will take, some effort on our end, how we are able to develop this, set of rules where they can safely use these resources, because we certainly don't want to take away these resources, but they can still develop their expertise on how to reach that conclusion. And I think a part of it, it can be where, these resources are taken away in some sim labs and things like that, and see how they function without it. Taking away technology never helps, I think. Teaching students to how to use that technology with certain safeguards, with more careful prompting, that is probably the way to go forward. Nothing.
Other questions? Go ahead, Josh, please. Dr. Sil.
Just press and hold, Dr. Sil.
No, it is refusing to get pressed.
So I'm always concerned about course development, the physician shortage that's impending.
Thanks, sir. And so, obviously AI can improve our, productivity a little bit, but my feeling is that it hasn't really moved the needle, a tremendous amount at this point. Probably in order to really help meet the workforce shortage and stuff, it's going to require a fair amount of autonomy on the part of AI, with physicians supervising, a pretty large amount of the work and that sort of thing. So how far away do you think we are in terms of being able to get by with fewer physicians because of all the increased productivity that AI is going to bring down the line?
Yeah, that's a great question. So I think there have been some studies that have looked at how ambient AI led to increased productivity and how the RVUs went up for certain practices when the physicians started using AI. And the idea of incorporating this technology would be to take away some of the administrative load from physicians, take away the less cognitive tasks from the physicians. But certainly at the end of the day, you're pretty much right. This technology at this point is an added tool, but it is not, we don't have confidence enough in this technology that it can function autonomously. So for that to happen, maybe we need to, as physicians, look at certain areas and try to pick and choose rather than trying to think how it can replace totally a physician, maybe choosing some of the areas that it can augment us maybe the approach going, that will help us going forward. And physicians would have more of like a supervision role in all of this rather than totally replacing us. I do not think that that is where we are at this point, and maybe perhaps in the 5 years going forward.
Other questions? Go ahead, please.
Hi, yes, thank you for your talk. Oh, can you hear me?
Yes, I can hear you.
Okay, awesome. I was just wondering, talking about just the bias that's being incorporated into AI, are there any counters for that that's in the works, or any way that that's being reduced?
Yeah, great question. So there is, when you are going into the specifics of these large language models, at the back end, there is training that happens. And just like you would train a child to learn things, they train an AI to give you outputs in different ways. That is quite a tech-based talk. But essentially, to answer your question, yes, they can put some guardrails around it, and those biases can be mitigated to a certain extent. Yes.
So how is that going to be regulated then? I'm just thinking, if there's multiple different types of AI systems out there, what is going to give the authority to say this AI needs to have that implemented? Or is it going to be based off of the company that's coming out with that particular source?
Yeah, good question. So whenever a new technology comes in, a lot of it is there are rapid developments happening. There's every day 5 or 10 articles coming. They're working on different new things. And then the idea how we are going to regulate it is always going to be something that's going to come across the board, and that usually comes from the government, right? So there would be some sort of guidance on it, how they are going to be incorporated. Like, for physicians, we have certain things that are there. For hospital systems, they have their own set of governance, and those rules would decide how these LLMs or AI technologies can be incorporated into patient care.
So law always lag behind significantly to new technological developments. So at some point we'll get there. Don't know when. Other questions? Yeah, but the bias, racial bias, gender bias, other biases have increased significantly over past year or so with newer models. Its hallucinations have dropped tremendously.
Yep, have dropped.
So there is really a lot of improvement in models' weaknesses that were identified early. Well, it's 1:03. Thank you very much, Dr. Mussarat, again.
Thank you, everyone.